delayed cholecystectomy. You may argue with me, this is not exactly the thing that is done. As I've said, depends on your institute what they follow. Majority of hospitals in this part of the world will follow this. And as an MBBS student in a good exam, I will request you to follow this. If you are planning an early cholecystectomy or early lap chole, remember the patient has to be coming to you within 72 hours. Patient should be fit for general anesthesia. No signs of sepsis should be present. इतना कुछ करना होगा. Then you know your patient you can be operating. But I feel better answer is initially operate ना करें, then followed by operation after 4 to 6 weeks. I will not tell you to operate immediately. No. What I teach in a postgraduate forum, I was teaching them PG-18 guidelines today afternoon. You are not required to say that in an exam. Kindly do not complicate your life in this point. This is a viva examination. This is not a show off of your gyan. So please do not say that. MCQs are there to show off the knowledge. The third of the scenarios is acute pancreatitis. Now, when I talk about acute pancreatitis, the typical presentation that you will be given is a college student or a businessman who was partying late night, etc., had an alcohol, and then thereafter the patient complained of pain in the upper part of the abdomen. Now, when he complained of pain in the upper part of the abdomen, the examiner is also telling you that the pain is radiating to the back. The pain is radiating to the back. What is the cause? Sir, I can think of only one cause. That is acute pancreatitis. No other cause produces a pain that can go to the back. So I think I will be only talking acute pancreatitis. The question is, how do you manage such a patient? The answer is in a viva examination. This is not a long question of 15 marks. 1 minute answer. Number one, I will resuscitate. Why? Because acute pancreatitis is associated with severe dehydration. Severe dehydration. The patient will have a low blood pressure. So please give Ringer lactate in bolus. Next one. Give the patient an NG tube. This decreases the distension of the abdomen. Number 3, IV PPI, because if you have a gastritis as a differential diagnosis, that takes care of that, and that's it. And number 4, you can put in a Foley cath. This is to monitor the urine output. Okay, job done. Have you completed writing?
Yes, sir.
Done, sir. Good. After resuscitation, तब क्या करेंगे sir? I will like to confirm my diagnosis by doing a blood for serum. Can you tell me the marker?
Amylase and
Lipase and amylase. That's it. That is what they want to hear, which are raised 3 times than that of the normal. Which one is more specific?
Lipase.
Lipase. That is what he wants to hear, sir, in an exam. And after that, what do you do? Sir, I assess the severity. But this is what he wants to hear. He is not asking you, Polo, Ranson score, bataiye, Dr. Saab. No, he is not asking you that one. He is going to ask you, do you know of any score? You have written that in theory. Ranson score, Apache score, etc. And based on the severity, sir, I will either shift the patient to the ward if it is mild pancreatitis, or the patient goes to an ICU if it is severe pancreatitis or moderate pancreatitis. Why? Because this patient needs an organ support. That's it. Please do not bring in CT scans at an undergraduate problem card table. I have seen examiners getting angry because they feel that this is not exactly the time. You have 1.5 minutes to the examiner, 2 minutes with the examiner, and believe me, this is what they want. This is not a theory long question. This is exactly that they want from you. The differential diagnosis in this area can only be a gastritis. That's it. So we have talked 3 causes. Right iliac fossa pain. This is the most common one asked in exams. Pain right upper abdomen, acute coli. Number 3, acute pancreatitis are the 3 most common things that you are asked in an exam. You can be asked it in a different way. Have you gone to the emergency? If you are asked this question, I hope you will say a big yes, sir, we have gone to the emergency. And if you have gone to the emergency, examiner will ask, what have you seen? Can you tell me what have you seen?
Acute cholecystitis.
Okay, so that means, sir, you want to talk the next 5 minutes on acute cholecystitis. Did you understand the way the exam goes? So it is up to you guys. So please get prepared in these topics. So these are the 3 most common problems that are asked across all institutes.
Sir, can you please scroll up once?
Which part?
Sir, I don't. Sir, नीचे दिख है. Oh, चारों नीचे. हाँ sir, ठीक. Thank you.
Talking about bleeding, non-trauma problem number 4 is bleeding per rectum. This is not a common question to be asked because it is felt that you are a undergraduate, you have not seen patients. You are asked about what are the common causes, particularly in children. Can you tell me a common cause in children? The answer is a polyp. And then bring intersusception. There is a reason behind this. So that the blood from a polyp is fresh blood. The blood, however, from an intersusception, what is the color called as?
Current
Red currant jelly. That's it. In an adult, what is the cause of a bleeding? Piles. Remember, P for P. Piles is painless. Whereas if it is a fissure, is painful. F for F. Please remember this way. In an elderly, 1, piles. Number 2, cancer, rectal cancer. Both of these are painless. So this is what exactly the examiner is wanting you to comment on a bleeding PR in a patient. Okay? So this is all about the causes of bleeding PR. Come to the next problem card. Hematuria. Now when you talk about hematuria, this is not exactly a surgery problem card. Examiner can ask you the causes of hematuria. You have written theory long questions. You know.
Sir, can you scroll up once? I will just take a screen.
So in hematuria, you are asked what is hematuria? What are the various, events
Okay, sir.
in hematuria? Or what are the various causes of hematuria? You will be asked a typical presentation of a patient with RCC or renal cell cancer, in which the patient not only has hematuria, but also the patient has a lump in abdomen, and also the patient has a pain in the renal angle. The hematuria in RCC is painless. Whereas if there is pain plus hematuria, and the pain in the hematuria is a renal colic, then the cause of this is a stone. कहाँ का stone? Definitely stone in which part, sir? Either a stone in the kidney, or a stone in the ureter, or a stone in the bladder. Anywhere you can have, but bladder may it will be cystitis. Kidney stones, ureteric stones will have a colic. Now, your question will be: a patient comes with a renal colic. How do you treat this patient? Simple answers. Number one, please don't say IV fluid, Ryle's tube. Please don't say those things. They are not very intelligent answers. Renal colic, the patient is screaming. Please give an injection of an analgesic. Do you know the name of this analgesic, sir? Hello?
Yes, sir.
Yes, sir.
Yes, sir.
Diclofenac. Okay. Followed by IV fluids. Number 3. Then go for an IV antibiotic, single dose. You may agree with me, you may not agree with me, particularly if the patient has fever. Remember, that means the patient is in sepsis, and it is good to think over giving at least 1 dose of antibiotic. Then step number 4, please do an X-ray of the abdomen. Today morning you have done the class on radiology. You know how does a renal stone look like. You know how does a ureteric stone look like. Where to find an ureteric stone, and you have also seen a picture of a bladder stone. You have seen all the pictures. In how many cases do you think you will get to see a radio opaque calculi?
90%.
90%.
And radiolucent? 10%.
10%.
Honors question. Can you name some radiolucent calculi? The mnemonic for this is Ixus, Triamterene, Indinavir, Xanthine, Urate, Silicate. Okay? Hello? Done?
So wait,
The last point, I will also may take the help of an ultrasound of the KUBP region. Can you tell me the full form of KUBP?
Kidney, ureter, bladder, prostate.
Wow, very good. Why have you done this? One line answer. To see hydro
nephrosis and ureter.
and hydroureter. Very good answer. This is what exactly an examiner is wanting you to say. Dr. Saab, you have 2.5 minutes or 3 minutes in this table. They are not asking you whatever you have written in long question, vomit kar dijiye. No. They are asking you to have a very schematic approach from you. This is what you are required to comment in the various non-trauma scenarios that you have talked. Now come to the trauma scenarios. Trauma scenarios are equally asked, depends upon your hospital or your examiner's fancy. In the trauma scenario, you are asked about what is the general approach that you do in any patient who has a trauma. Now, any patient who has a trauma, that can mean a patient with an abdominal injury. It can be a 12-year-old boy who has a suspected spleen injury. It is the same approach. It can be a patient with a trauma or a CNS trauma. It can be the patient with a spine trauma that the orthopedic surgeon may ask you. It can be the patient with a pelvic trauma that again the orthopedic surgeon loves to ask you. It can be the patient with a fracture of the femur that again the trauma guy can ask you. But remember, the general approach is the same. What is the general approach? Sir, I will work in a team approach. This is what exactly the examiner wants to hear. I will work in a team approach. ये आपको किताब में नहीं मिलेगा. Number 1. Number 2. I will go for airway which is secured. Number 2. Breathing. That means I will auscultate the chest for air entry. Circulation. I will assess. I will start IV fluids. Ringer lactate. Give 1 liter of IV fluid and then see the blood pressure. ये मत बोलिए कि I will see the blood pressure and then give the fluid. No, you don't waste time. You give IV fluids and then decide what is to be done. With this, it is better that you should have said parallelly, I will do a cervical spine support with a cervical collar. That's it. Next one, always remember, I will assess the disability by something called as a Glasgow Coma score. And finally, I will go for exposure and environmental control. What do you mean by these two words? Environmental control means wrap up the patient in a blanket to prevent what problem? Hypothermia. But before you wrap up the patient, what should you do? You expose the patient from the head to the foot for any external bleeding. I will again repeat from the beginning. What is the first thing that you will say to the examiner? What is the first thing that you will say to the examiner? I will work a team approach. Then you know the A, B, C, C, D, E. It is not A, B, C, D, E. It is A, B, C, C, D, E. A, B, C, C, D, E, E. Please remember this is what the examiner wants to hear. A, B, C, C, D, E, E. This is all that he wants to hear from you. Any trauma patient, does not matter. Now, after you have managed the patient, then come to particular injuries. Say, for example, abdominal injury. You have had your long questions that you have written on abdominal injury, blunt trauma to the spleen. You are asked about what is the algorithm that we follow. The answer is very simple. In an abdominal injury, we see if the patient is hemodynamically stable or unstable. If the patient is hemodynamically stable, we go in for a clinical examination. If the clinical examination shows peritonitis, we go in for a laparotomy. If the clinical examination shows doubtful features, we go in for a CT scan. And if the clinical examination shows no clinical signs, I observe. If the patient is hemodynamically unstable, I go for examination called FAST. What is the full form of FAST?
Focus assistance.
Focused assessment and
Focus assessment sonography in trauma. What does it show you? If there is blood in the peritoneal cavity. If there is blood in the peritoneal cavity, you go in for a laparotomy. Positive is blood. That is all that people want to know from you today. They do not want बोलिए grade up spleen injury, बोलो grade 2 na grade 3. These are postgraduate questions. Have I made you understand this point, sir?
Yes.
Yes, sir.
If you have taken down the notes, then we'll proceed. Done?
Done, sir.
Can we scroll up one second? Yes, sir.
Right. Similarly, so this is all about abdominal injuries, which a general surgeon is likely to ask you. Then, exactly in the same lines, you have a patient with a burn injury. Now, this is something that needs your attention because this is a common problem in majority of hospitals. Remember, the burn injury, two things are asked for you. What is the initial management in a burn injury patient? This is something, remember, is a viva examination and your answer has to be very brief point. Sir, I will follow the team approach. Then I will go by the A, B, C, D, E approach. And after I have done this is technically called as the primary survey. And after I have done this, then I will see the blood pressure of the patient and definitely see the blood pressure, see the pulse rate of the patient, and these are the vitals that are monitored. So this is the initial management that is always done. With this, as a part of airway management and as a part of breathing management, it is important that I start the patient on moist oxygen inhalation at the rate of 4 to 6 liter per minute. This is something that the examiner is wanting you to say. What is the fluid that you will give? Sir, मैंने बोल ही दिया है, you will give ringer lactate. That's it. Please tell me when you have completed writing.
Done.
Good. After this, the examiner says, okay, you have managed it very nice. When the patient goes to the ward, क्या करेंगे आप? Sir, I have 3 responsibilities. This is what exactly we do. Number 1, we calculate the fluid requirement. Everyone knows this. Number 2, we cover the or manage the burn wound. And finally, remember, we take a detailed history for medico-legal purpose. You are asked about this. What do you mean by this statement? The best example of this is a 22-year-old lady who has been recently married is admitted to you with 40% burns. What is the medical legal concern in India that I am worried with?
Dowry.
Or dowry debts. Very good. So you know about this one. This is what you are asked in exams. Now, How to calculate the fluid requirement in burns? Sir, it requires a formula. What is the formula, sir? It is called modified Parkland formula. What is the formula? First 24 hours. 4 into the percentage of the burns into the body weight. Okay, so this is what is important. This is divided into two parts, right? So this is divided into two parts. In the first 24 hours, 50% is given in the first 8 hours, and 50% is given in the next 16 hours. Remember, the time starts from the time of burns. That is important. Time is from the time of burns, not the time he comes to you. Now, with this formula, what is the fluid that you are giving? Is always Ringer lactate, which is a crystalloid. Can you name me a colloid that is used in burns? One word answer, please. Can you name a colloid that is used in burn management? That is albumin. Okay, right. When Parkland made the original formula, he had albumin and crystalloid, both of them. Hello, am I audible? Hello.
Yes, sir.
Yes, sir.
So when Parkland made the original formula, he had albumin in mind. Then people told him, Baba, albumin itna costly ho gaya. So he took off this one, made a modification, only crystalloid with Ringer lactate. Now that makes us ask you another question. How did you calculate the percentage of burns? Very good.
Rule of
This is something called the rule of 9.
Sir, but in case of normal burn in modified Parkland's formula, it is now modified to 2 into 1%.
No, absolutely not, sir. Absolutely not. No, absolutely not. Sir, again, you are making a basic fundamental mistake. Please see your theory notes. 24 hours to 48 hours, the formula becomes 2 into percentage into the body weight. From 48 hours onwards, this becomes 1 into percentage into the body weight. Have I made you understand this point, sir?
Okay, sir.
Calculate the percentage of burns. One line answer, rule of 9. So please remember this one. The rule of 9 is important in this. In the rule of 9, always remember this one. And what is important in this story about the rule of 9 is because this is something that has become important for more or the less all people have gone on repeatedly asking you about what is the rule of 9, what should be the various components of a rule of 9, etc. So this is important, and I hope all of you have known about what is the rule of 9. We'll not talk about the rule of 9 in this part, but what is important is understand that the rule of 9 or components of the rule of 9 in adults and children, it differs. If you have known the adults, that is very nice. Remember that in the adult part, what is important is the face and the neck are given 9%, the full torso is given 18 plus 18. So it is 36% on the torso. Torso means anterior 18, posterior 18. The upper extremity is 9 and 9. The lower extremity is 18 and 18. So, and the genitalia is 1. So, this is what I remember, and all examiners will ask you this question, sir. Please remember this part. Whereas if you talk of a children, remember in a children, the matha is not given 9, it is about 19. The trunk is 32. Upper extremities are 9, 9. The lower extremities become 15 and 15. So this is the difference in the rule of 9 in ones. You are expected to know this. There are minor variations in books, but this is what exactly around is the picture. I expect you to know the adult wala burn injuries in this point in details. So these are the various problem cards that you will be given in your exam. Remember that problem cards are usually meant to ask you whether you have gone to the hospital to manage patients or not. So examination questions can be very practical ones. Usually they are practical ones. If you are asked about what is done, some centers can ask you common questions like a patient presented with a hand injury or an injury in other body parts. How do you manage these injuries? Now see guys, injuries are very simply managed. So for example, someone has an hand injury. The basic part of hand injuries are you go for a compression of these injuries. Sometimes you can put a bandage, and by the time you put a compression and a bandage, then you assess the vitals of the patient, assess the blood pressure, assess the pallor, and start an IV fluid. So like any trauma management, this is basically the story. After you have done this, then open the dressing always in a operation theater or under a good light. And then the basic problems are do a good hemostasis, go for a good cleaning of the wound. This is called as debridement. That means you are trying to clear the wound of all foreign bodies and say broken pieces of glass, etc. After you have done this thing, you ask yourself only two questions. Is it a tidy wound? Is it an untidy wound? If it is untidy, do not suture, do not suture, do not suture. Keep the wound open and write open dressing. If it is a tidy wound, then please go for suturing of the wound. Where will you get the definition of tidy and untidy? Which chapter have you read tidy and untidy wounds?
Wound infections.
Is wound infections and wound healing. That is all. Examiner will ask, बहुत अच्छा लगा सुनने में, क्या देंगे आप छुट्टी के time? You are trying to discharge the patient. You are an intern.
Antibiotic.
What will you advise? Now, sir, no, sir. Yeah, I'm going to advise injection, tetanus, toxoid, booster dose. But definitely it will depend upon the immunization status of the patient. But wounds which are untidy, it is important that you must advise for an injection of tetanus, human antibodies called TET-glob. This is that wound that needs a tetanus. This is what the examiner is wanting. Antibiotics, we are not interested. We are interested whether you have taken a tetanus prophylaxis or not. This is what is very important. And last one, there should be a proper documentation of the wound in the discharge. This is for a medical legal purpose. Okay, so this is all about the various trauma. So 3 kinds of scenarios I have told you. Hand injuries. It can be injuries in other parts of body as well. It could be the rule of 9 and burns, and it could be abdominal injuries and trauma. So this completes more or less all your trauma cards. Majority of hospitals, I think, will be going through this kind of trauma patients to be asked about. Particularly, remember the initial management of trauma is the same, even if you are talking of a spine trauma, CNS trauma, pelvis trauma, femur trauma, chest trauma. Chest traumas are asked only in that X-ray that we have discussed. You are not asked usually in a problem card because examiner will have problem in making you ask why is it a pneumothorax. You need an X-ray for that. So that is tackled that we have completed in that X-ray part, nothing more. The important things only to ask in this problem card section is one. Examiner is wanting you to understand the A, B, C, D, E approach of trauma. This is what he is wanting to know. So this is the basic problem card. Now, in a problem card, there could be less common examples that can also be given. Like I had once seen a gentleman asking about a thyroid lump, which you should not have asked, or a patient with a breast lump. Again, these are questions that you have already answered in your long case. What is the approach to a patient with a breast lump? What is the approach to a patient with inguinal hernia? We are not interested in that because that has been covered in your long cases. This table is about usual problems that an intern is expected to face in his emergency, particularly in emergency because he is alone, or in the ward when he has seen such patients. So this is all about the problem cards that you are required to know. Okay, so this completes all parts of your practical exams. You have completed long case, short cases, operative instruments, specimens, and problem cards. Okay, your questions and queries, please.
Sir, আমাদের কলেজেতে
বলেছিলাম যে সার্ভাইকাল ম্যানেজমেন্ট সার্ভাইকাল কলাটা আগে দিতে হবে দেন এয়ারওয়ে ম্যানেজমেন্ট টেস্ট মানে
again, now that is good point, very good point raised. The problem is that as I have told you, this is not a vertical integration. You have told me a very important word that I did not wish to bring about, because the more I bring about this word, the more will confusion start. If you are thinking we have done a B, C, D, E, this is a vertical approach, this is wrong. The approach technically should always be a horizontal approach. That means I told you, if you are the man who is looking after the A, there is another one who is looking after the cervical collar. There is another one who is looking after the circulation. There is another one who is auscultating the chest. And the last part, someone is looking for the exposure and the environment. So basically, I told you, we have a team. The team has the responsibility. But if you are alone in emergency, then what will you do? Then go by the ABCDE approach. Okay, right.
But sir, as the problem carded acute pancreatitis is under a based on severity slide টা একটু প্লিজ দেখাবেন স্যার, একটু নিচের দিকে ER এর পোর্শনটা।
There is nothing more than that, sir. There is a smiley face.
ওকে স্যার, থ্যাংক ইউ
স্যার আমাদের কলেজেতে ইলেকট্রোকিউশনের একটা কার্ড আছে।
Sir, electrocution is again a burn injury. The basic idea in electrocution that the examiner is wanting you to hear is that after you have tackled the A, B, C, D, E in burns, I will start IV fluids. Very good. Examiner is wanting you to hear 2 words. Always do a Foley catheterization because patient can have a myoglobinuria, and always do an ECG because patient can have an arrhythmia. This is what he wants to hear from you.
Okay, sir. Thank you.
Okay, right. If there are no other questions, chalo. Thank you everyone, and best of luck for your exams.
Thank you, sir.
Thank you.
আমাদের
Thank you.
ক্লাস হবে
I think we have finished the practicals. I don't think any other topics are left, sir. At least in general surgery, there are none.
স্যার হার্নিয়া থিওরিটা একবার একটু করিয়ে দিলে কমন হয়
Hernia
থিওরি
theory. Sir, I think I've completed hernia theory the last year. So if I will be completing the hernia theory with the with the sixth semester, so I think please get in touch with Shamulda when I'll be taking a class on hernias and abdominal wall. Okay, I will again, so please join that class. If there is a class on sixth semester, I think they will be having a class very soon. Hernias and abdominal wall. They will have umbilical hernias, ascites, and those things again. So please join that class. Hernia
sir.
is long case. Hernia, the main thing is long case. If you have done the long case, that is what main thing in an MBBS hernia class is about. Short case, we have talked about epigastric hernia, umbilical hernia, then incisional hernia. So we have completed the three.
and specialty surgeries like neurosurgery, plastic surgery, ovular.
Sir, I think we have completed it the last year. Get in touch
না
with
স্যার
Shamulda.
আমাদের পেডিয়াট্রিক সার্জারি নিউরোসার্জারি ওইগুলো হয়নি স্যার
So get in touch with Shamulda if there are some topics left. I think this sixth semester batch will be starting with super specialties very soon. So please join them with the class. Okay, right. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
থ্যাংক ইউ স্যার
Recording stopped.
গাড়ি রাখা গাড়ির উপরে বাম দিকে